All right, it is 12:01, so we'll go ahead and get started. Thank you for all of you for joining, and welcome to Medical Grand Rounds at the University of Colorado. My only announcements for today are to wish everyone a happy holiday. Holidays obviously started at the end of November and will run through the beginning of January. For whatever you are celebrating, I hope you enjoy some time with your family. To that end, I want to remind everyone to please be safe around Omicron. The data coming out are increasingly nasty, I think is the best way to say it. Our test positivity in Colorado here is up to a fairly staggering 18% this morning. And so certainly be with your loved ones, but I'm just encouraging everyone to be as safe as possible anytime you're out in the world. Please use the link in the chat to sign up for MOC and CME credit that is available for all medical grand rounds. Please use the Q&A for your questions. The chief resident and myself will take questions for Dr. Hackett at the end of the talk. And now I'd like to introduce Dr. Peter Hackett. He is truly one of the world's foremost experts on the effects of high altitude and high altitude medicine. He got his MD at the University of Illinois. He was an intern in medicine and surgery at UCSF General Hospital, and then was a fellow at the Cardiovascular Pulmonary Research Laboratory at the University of Colorado in the 1970s. He has been an affiliate professor at a number of institutions, including the University of Alaska, the University of Washington, but has spent most of his time as a clinical professor of emergency medicine and medicine here at the University of Colorado. He currently is a clinical professor of medicine at the Altitude Research Center in the Department of Pulmonary and Critical Care Medicine at Colorado. He is also the leader of all educational clinical research and day-to-day efforts at the Institute for Altitude Medicine in Telluride, Colorado. He's written over 80 manuscripts on the effects of hypoxemia and hypoxemia research. He has been invited to deliver the President's Lecture for the ATS. He was the Bauer Lecturer at the Aerospace Medical Association and the President's Lecturer at the Society for Critical Care back in the early 2000s. He has been the president for the International Society for Mountain Medicine, co-chair of the International Hypoxemia Symposium, been a board of directors of the Wilderness Medical Society, and was involved in incredible things in his career, including the first hang glide attempt over Everest and working with the Himalaya Rescue Association in Nepal. Truly a world's expert in high altitude research, a leading authority on altitude illness, high altitude climbing, wilderness medicine, and the effect of altitude at people living and working in the mountains. He has been at the frontier for altitude research for a number of years. We are fortunate today to have Dr. Peter Hackett join us for Medical Grand Rounds.
Well, thanks very much for that introduction. And I also play Santa Claus this week from some grandkids. But our topic today is about the limits of human hypoxia, what we can learn from the death zone on Everest. And by death zone, we mean over 8,000 meters or 26,000 feet. I'm broadcasting, if you want to call it that, from Ridgeway, Colorado. Very comfortable here with an arterial PO2 in the low 60s. And hope you're enjoying the thicker air down there in Denver. We'll start with the case presentation, then we'll go into high altitude physiology and pathophysiology and clinical issues. I want to start with this remarkable story of Lincoln Hall. He's an Australian climber who made it to the summit of, he's an experienced mountaineer, made it to the summit of Everest. On the way down, he began to hallucinate and collapse several times. His mates assumed he had high altitude cerebral edema. The Sherpas did their best to try to keep him moving, but eventually he just collapsed and couldn't move any further. They left him for dead about 5:30 in the afternoon. He wasn't moving, he wasn't talking. 12 hours later, an American climber came up, and this is what he wrote. Sitting to our left about 2 feet from a 10,000-foot drop was a man, not dead, not sleeping, but sitting cross-legged in the process of changing his shirt. He had no oxygen mask, regulator, ice axe, sleeping bag, mattress, food, or water. I imagine you're surprised to see me here, the man said. Now, this was a moment of total disbelief to us all. Here was a gentleman, apparently lucid, who had spent the night without oxygen at 28,200 feet, without proper equipment and barely clothed, and he was alive. It's a remarkable story that anyone could survive that degree of hypoxemia. Another quick story was Tom Hornbein and Willie Unsold back in the '63 Everest expedition. First American ascent of Everest, reached the summit and then bivouacked on the way down below 28,000 feet, ran out of oxygen and survived the night out without supplemental oxygen. A picture of him and Willie Unsold, practically unscathed. That is, they were able to get down on their own power, although suffering from some frostbite. Well, how can humans survive in this kind of climate where the oxygen level is 6% of what it would be at sea level. And indeed, is Everest the limit? We'll explore some of this, and then hopefully we'll have some good time for discussions. One of the pieces of evidence that is to the very limit of adaptability is that it took 54 years to climb that last 1,000 feet from 28,000 to 29,000. In the 20s and 30s, the Brits had gotten to 28,000 feet without oxygen, but it wasn't until 54 years later that Messner and Hobler climbed it for the first time without supplemental oxygen. Of course, 25 years earlier, in 1953, it was climbed with oxygen by Hiller and Tenzing, which everyone is familiar with. What's the problem? The problem, of course, is low inspired pressure of oxygen, or low PO2. Hypobaria per se doesn't have much effect on the body, if any, in terms of oxygenation or performance. And here we see a graph of barometric pressure in millimeters mercury, altitude in meters and feet. I'll be interchanging meters and feet a lot because my sources are using one or the other. I hope that's not confusing. Here we are in Denver, inspired PO2 of around 120 or so. Ski resorts. Highest human habitation is around 5,000 meters, or around 15,000 feet. No humans can survive for a long time above that period and reproduce and function. And then there's Mount Everest at about 1/3 atmospheric pressure and about 1/3 of inspired partial pressure of oxygen. So it's all about barometric pressure and partial pressure of oxygen. Don't let a student confuse you with or try to trick you into saying that air on some of Everest has less than 21% oxygen. All air has 21% oxygen, but it's 21% at fewer and fewer molecules as one ascends to a higher altitude. What else influences barometric pressure besides elevation? Well, seasons can, and weather. We see here, this is in barometric pressure in millimeters mercury versus latitude. This is the latitude of Everest at about 28 degrees north. If Everest were at the latitude of Mount McKinley in Alaska, it could not be climbed without supplemental oxygen. So that tells you we're very close to the actual limits of human performance. In addition, weather. These are data from Moore and Semple looking at barometric pressure in 1 month. May 1996, the time of the Indo Thin Air disaster. You see that these fluctuations are pretty considerable. They amount to about 3% in barometric pressure. Well, you might not think a 3% change in barometric pressure makes much of a difference, but at that altitude, a 3% change in barometric pressure amounts to a 15% change in VO2 max because of the difference in availability of oxygen. Of course, at sea level, it wouldn't be anywhere near that much of a change. But that, again, tells us we are indeed at the very limits. And how do humans do it? Well, if we follow a molecule of oxygen from the air to the mitochondria, which is their ultimate destination, of course, then we talk about the oxygen cascade, which involves multiple organ systems. We see here that at sea level, there's a huge supply of oxygen. I mean, much more oxygen than you would ever need in terms of what's required for at the tissue, looking at a mixed venous level. And you can see that the big drop here is from atmospheric to alveolar and then across the capillary as it's unloaded. And the main way that humans adapt to high altitude is by decreasing these gradients in order to maintain a PO2 that is compatible with survival. So the summit of Everest would be just below here. And we see that we're going to talk about this increase in ventilation, which is so important on ascent. As you know, it's this carotid body, this little 3-gram organ, and that's just a bifurcation that senses arterial PO2, not oxygen content, and sends signals to the brainstem, to the respiratory control centers to increase ventilation in the face of hypoxemia, or actually, yes, hypoxemia. And this response is quite variable. It's genetically determined to a large extent. It can also be influenced by other factors as well. The real key here to understand is that if you didn't hyperventilate, if you did not increase your alveolar oxygen by increasing your ventilation, you could not go higher than 16,000 feet. Because at that altitude, your arterial PO2 would be the same as a climber on the summit of Everest without oxygen if your PCO2 were 40 instead of 8 or 9, which is the measured value. What is alveolar oxygen on the summit of Everest? This is Chris Pizzo, a pathologist from Denver who was on our Everest trip in 1981. He's exhaling on the summit into an alveolar gas sampler and collecting air samples that were then later analyzed. And the results were rather astounding. Based on blood that we drew on each other, Chris and I did on the South Col, this is what we found. The barometric pressure, first of all, was higher than expected at 253, about a third of low altitude, which gives an inspired PO2 of 43, an alveolar of 35, an arterial PO2 of 28, and that's with extreme hyperventilation, with an arterial PCO2 of 7.5 and severe alkalosis. How many of you have seen these kind of blood gases in clinical practice? I mean, normally when you see a patient that's hypoxemic, they're not hyperventilating like crazy. And of course, they're not talking to you and asking for a cup of tea. These data were later confirmed by another expedition that took place. They actually did femoral sticks, these anesthesiologists from England, on the Caldwell Extreme Everest expedition, and published in the New England Journal because it was so remarkable. About the same values, extreme hyperventilation with only a moderate renal compensation so that they're still alkalotic. Arterial PO2 that averaged 25 with a range from 19 to 29, and an average oxygen saturation 54%. Of course, at these extreme altitudes, you're on such a steep part of the oxygen dissociation curve that even a 1 or 2 millimeter change in arterial PO2 is going to cause a significant change in saturation. So saturation values tend to be all over the map. And of course, they're a bit hemoconcentrated as well as somewhat polycythemic. So multiple data points and chamber studies all indicate that humans, healthy humans, functioning fairly well, can tolerate arterial PO2s in the range of the low 20s to mid 20s and oxygen saturations 50 to 60%. The body, given a choice between keeping pH normal or defending alveolar PO2, decides to let pH float. In other words, induce an extreme alkalosis in order to defend alveolar PO2. There's apparently the human body cannot tolerate or will not tolerate an alveolar PO2 less than about 35, which would be an arterial PO2 in the mid 20s or so. So if you look at this series of acclimatization figures or data points, you see that extreme hyperventilation is indeed the key to operating in this kind of environment. Well, what about the lung? The lung's doing a lot of work with that amount of hyperventilation. The mechanics, fortunately, are unchanged, even though there's generalized muscle weakness. Respiratory muscles seem to stay intact since we're using them so much. The air is a lot thinner, so it's actually easier to move air, but you have to move a lot more air than you did below. There's a diffusion limitation, which is the hallmark of altitude desaturation. That's much worse with exercise. We'll look at that. VQ mismatch of varying degree. Peter Wagner and others actually did swan gas catheters in an altitude chamber at 28,800 feet and were able to do multiple inert gas technique and show that there is significant VQ mismatch at rest and with exercise. Possibly due to subclinical interstitial edema, which has been suggested in a number of other studies as well. And then, of course, because of the hypoxia and the hypoxemia, there is significant pulmonary hypertension, which can be a limiting factor to performance with a strain on the right ventricle, which eventually can also take a toll on the left ventricle. So here we have time along the capillary in the pulmonary capillary versus PO2. The red cell comes into the lung at sea level at a mixed venous PO2 of about 40, and within 0.2 of a second, it's completely equilibrated because the diffusion pressure for oxygen is quite high. At high altitude, it comes in to the lung at a mixed venous PO2 of about 21, and in 0.2 of a second, it hasn't had time to equilibrate at all because the diffusion pressure is so low. And by the time it exits the lung, it can't fully equilibrate with this low alveolar oxygen tension. So that is the hallmark of diffusion impairment. And of course, what happens during exercise? The time along the cardiac output is increased, red cells move faster through the pulmonary circulation, and the diffusion gradient becomes greater, oxygen saturation, and arterial PO2 drops even more. What about the heart? The heart is doing a lot of work, pushing around an increased hemoglobin mass and pushing against increased vascular resistance in some vascular beds. Well, the heart is amazingly tolerant of hypoxia. We and many others have done multiple ECG studies at these extreme altitudes and at extremely low PO2s. And we see minimal ST changes, some flattening across the T-waves and in the, across the chest. And that's about it. I mean, there's no evidence of ischemia. The heart, very tolerant of the hypoxia, not so tolerant of ischemia. Very important to recognize that difference in all the organs, brain and heart especially. The heart is able to match the work as it is at sea level. That is, for the given amount of work, it produces the same cardiac output after acclimatization. In terms of adaptation, it increases coronary blood flow quite a bit, which means people with diseased coronaries might not fare so well. But in healthy persons, this is not an issue. And of course, there's metabolic changes and cellular changes. For example, cardiac myocytes are going to cell cycling, which is very unusual, in response to very low oxygen levels, and actually start making more muscle cells. Here we have a graph of oxygen uptake versus cardiac output at high altitude and sea level. You see that with acute exposure, there is an increased cardiac output for the same amount of work. In other words, more of a strain on the heart to get the same amount of work done. But after acclimatization, perfect matching. The bottom line is that the heart will do whatever work you ask it to do at high altitude in terms of muscular exercise. What about the rest of the cardiovascular system? This was a nice little American Heart Association statement published by Bill Cornwell from Denver and others that looked at the effect of high altitude on people with cardiovascular conditions. And it's worth reading if you have patients with cardiovascular issues. And they noted the hypoxic pulmonary vasoconstriction, pulmonary hypertension, the increased sympathetics leading to increased cardiac output, mostly because of increased heart rate, while plasma volume is actually depressed. And systemic arterial vasodilation followed by vasoconstriction, secondary to sympathetics. So it looks like you would expect the heart to do more work, but indeed the heart does fine. What about hematologic acclimatization? Everybody thinks you got to have more red cells to do well at altitude. Unfortunately, not that helpful, especially at very high altitude. The oxygen carrying capacity does increase immediately on ascent to altitude because of a decrease in plasma volume. Even if you go today from Denver to Pikes Peak and hang out there overnight, you'll get a 10 to 15% drop in your plasma volume within 24 hours to 36 hours. And that increases the oxygen carrying capacity per unit of volume unit of blood. The increase of red cells, as you know, and the increase in hemoglobin mass can take weeks. Starts immediately, but it takes a long time to actually impact hemoglobin mass. So putting it together in terms of oxygen transport, these are data from the Extreme Everest expedition. We look at partial pressure of oxygen, arterial oxygen saturation, hemoglobin concentration, and arterial oxygen content. We see that up to 6,400 meters, There's an increase in arterial oxygen content, but then a decline because of the persistent decline in arterial PO2 and oxygen saturation with a sense of altitude. So that performance does not appear to be enhanced by this increase in arterial oxygen transport. There's much more to the story than just what's in the arterial blood. And that gets down to the microcirculation and the diffusion of oxygen and the unloading of oxygen from the hemoglobin. We all remember, I'm sure you fondly remember from your medical school days, the oxygen dissociation curve. And you remember that on ascent to altitude, you may remember it, it's classically taught that a right shift improves unloading at the tissues and therefore is beneficial. We now know that that's true to some extent up to about 17,000 feet or 5,500 meters. A right shift can be beneficial in terms of delivery to the tissues because there's still enough oxygen picked up in the lungs. But once you get above 5,500 meters, the situation is changed and a left shift becomes advantageous because it's so much more important to load oxygen onto the cell in the lung so that it can be transported down here where local tissue factors will unload it probably just fine despite the somewhat leftward shift. The local tissues are so hypoxemic that there's an interaction that takes place that helps to facilitate transfer of oxygen into the cell. The transfer of oxygen is complicated business from the hemoglobin molecule in the red cell to the mitochondria in the working muscle or neuron. It involves transport across membranes, through the plasma, through the cytosol. There's tons of morphologic and hemodynamic heterogeneities that come into play. The hemoglobin and myoglobin themselves have impacts on diffusion. And here's a good trivia question. I meant to put this to you. And if I've never seen it in a Trivial Pursuit game, but what is the normal PO2 in the mitochondria? The answer is it's less than 1 millimeter mercury. In fact, there's a whole school of thought that this oxygen cascade from the ambient air and all the levels down to the mitochondria is there in order to assure that the cells do not suffer from oxygen toxicity. It's a really interesting concept and has some validity. Then there's the muscle metabolic changes. There's the increase in capillary perfusion, capillary recruitment in most of the vascular beds. But in the muscles, there's a decrease in fiber size, which actually leads to a decrease in oxidative capacity. And at very high altitude, there's an increase in glycolytic capacity. This is associated with a decrease in mitochondrial volume. But because the muscle fiber size is down, the capillary to fiber ratio or capillary density is actually increased so that the oxygen supplied to the fewer mitochondria there is actually improved. There's also a tremendous increase in lipid peroxidation. 20 years ago, you could start an argument at a hypoxia meeting by suggesting that hypoxia triggers inflammation. There's no question these days that hypoxia does induce reactive oxygen species, which can be beneficial in terms of inducing oxygen responses, but can also, of course, be detrimental. Here's a schematic showing a myocyte at sea level and a myocyte in an acclimatized lowlander or Tibetan. There's more capillaries per muscle fiber because the muscle fibers are actually smaller. There's controversy about whether or not the body actually makes new capillaries. The mitochondria are redistributed. There's much fewer in the subsarcolemmal area of the mitochondria, of the muscle, I mean, and fewer mitochondria overall. HIF is the magic trigger in the body that's responsible for most of these oxygen responses. HIF was only recently described, maybe 20 years ago. And I don't need to go into detail about this, but you know that in every cell in the body that has a nucleus, in the presence of normal oxygen tensions, HIF is degraded within a minute or two after it's produced through von Hippel-Lindau factor and ubiquitization. However, in the presence of hypoxia, it stabilizes. The reason it stabilizes in the presence of hypoxia is because the prolyl hydroxylase enzymes that initially start the degradation process are inactivated. When there's more HIF around, it binds to the hypoxia-responsive elements in the nucleus. As a transcription factor, it activates transcription of hypoxia-responsive genes. Here's the next trivia question. How many genes are impacted one way or the other, either turned on or turned off or modulated by HIF? 5, 50, 100? No one would guess 5,000, but that appears to be about the current number. About a quarter of the human genome has some relationship to HIF transcription factors, which I find amazing. And in fact, the science of HIF biology has just exploded with over 24,000 papers published right now and more each year on hypoxia-inducible factor. A big boon to the field of high altitude medicine and hypoxia was that the Nobel Prize in medicine was awarded to these 3 researchers that are credited with discovering HIF. And Grace Menza and Peter Ratcliffe are both regular attendees and presenters at our International Hypoxia meeting that takes place every 2 years in Lake Louise, Canada, and will be happening again in February of 2023. So to summarize, acclimatization and surviving at these extreme altitudes depends on extreme hyperventilation, marked respiratory alkalosis. Because of incomplete renal compensation, there's a persistent alkalosis and a left shift of the oxygen dissociation curve. A very low VO2 max. VO2 max near the summit of Everest is only about 1 liter per minute. And progressive deterioration, which I don't have time to go into. Trouble with sleep, with appetite, maintaining weight, and losing muscle is inevitable. In other words, in the death zone, despite being able to survive, the human body is dying. It's dying at a relatively slow rate. It'd probably take days to weeks to die in the death zone if you don't have supplemental oxygen. That study's obviously never been done. So to survive there at all is kind of remarkable. What's the best solution to dealing with life in the death zone is to use oxygen. So this is a graph, courtesy of Tom Hornbein, that shows a flow of supplemental oxygen in liters per minute, and the mask altitude, which is similar to cabin altitude in an aircraft. Because the FiO2 is increased, it's the same as dropping altitude. These are at constant flow rates. So the mask delivers, the tank and the regulator and the mask deliver a set amount of oxygen. That is diluted with the inspired air that you get from outside the mask. You have to have that in order to breathe these very high volumes of air. So if you're breathing 25 liters a minute, which would be at rest at extreme altitude, but 4 times normal at low altitude, you're going to have a much higher FiO2 and therefore a lower effective altitude or mask altitude. Whereas if you're breathing at 125 liters a minute, or 150, which is close to what I was breathing near the summit of Everest without oxygen, you're going to dilute it much more, and therefore the mask altitude won't be nearly as low. So it boils down to an FiO2 of about 0.28 at rest. If you're at these kind 1 liter flow, about 45% oxygen with this ventilation if you're at 4 liters flow. And that enables people to survive and perform much better, because now their body, instead of being at 8,800 meters, thinks it's more at 6,000 meters or even lower, that is 20,000 feet. I was when I went to the summit, I was on 1 liter of oxygen. So my flow rate would be up here, and I was working about here. So instead of, my body thought it was at about 26.5 or 27 instead of being at close to 29,000. A big advantage. This is the Hornbein mask from the 60s with a reservoir bag, continuous flow. This is newer mask with demand valves, but it's operated with some electronics and batteries, which can be a problem at high altitude. And here is a popular mask system, an oxygen system. The oxygen cylinder weighs about 8 pounds. with the mask and everything is maybe 9 or 10 pounds. So it involves carrying that much extra weight, and you have to carry 3 or 4 bottles on summit day. But nowadays, everybody has Sherpas to do it for them. It's not as much of a negative. So let's move on now to the pathophysiology and the clinical problems. I suppose the ultimate clinical problem is death. We see that the death rate on Everest from this paper in 2020 show that it's pretty constant over the decades, about 1%. Well, the number of successful climbers has mushroomed from 20% to about 60%. That means more climbers are getting up into the death zone, but the death rate is still relatively stable. Deaths on descent are more common than deaths on going up. If you look more carefully, this paper on which Rob Roach from Colorado was an author, Paul Firth was first author, the number of deaths, you see that most of the deaths are above the line for the death zone, which is where there aren't avalanches and there aren't many falls. Most of these deaths are from hypoxemia and exposure, hypothermia, the combination. Rather remarkable if you look at the death rates compared to Everest on oxygen versus without oxygen, or even more profound, K2 with oxygen and without oxygen. One can draw easy conclusions from that. Overall, the death rate isn't that different between oxygen and no oxygen on all the 8,000 meter peaks. And the reason for the difference is that Everest and K2 are so much higher, even though they're 8,000 meter peaks. They're up by closer to 29,000, where the lower 8,000 meter peaks are at 26,000. Again, showing we're right near the limits of human possibility. Why do people die in the death zone? Extreme hypoxemia, fragmented sleep, and haze. Often it boils down to what happens in their brains. We'll go into that a little bit. So if you run out of oxygen, your oxygen saturation is about comfortable 80%, and you suddenly run out or take your mask off, you drop to 55%, it might not be too bad if you're not totally dependent on oxygen. That is, if you took some time to acclimatize. But if you didn't, you could develop rather quickly high altitude cerebral edema, which typically comes on slowly in people with symptoms of AMS, and especially if they have high altitude pulmonary edema, but it can come on more rapidly. Of course, it's very hard to tell the difference between just hypoxic cerebral function, cerebral hypoxia, and high altitude cerebral edema, and especially in these places where studies aren't being done and clinical observations aren't robust. The first description of vasogenic edema as the cause of high altitude cerebral edema came from Colorado, a study we did in skiers with high altitude cerebral and pulmonary edema in ski resorts. And we showed increased typical MRI that's typical for this condition, of increased T2 signal on these T2 weighted images. We also showed more recently, and others have, the evidence of microbleeds indicating clearly a violation of the blood-brain barrier with extravasation of red cells into the brain parenchyma. These don't go away with time. These can be permanent. They're like a stamp on the brain. There's no persistent brain damage, but the hemosiderin is deposited in these tissues, and it makes a strong MRI signal. So you can diagnose cerebral edema of altitude sometimes years after the event if you find these typical microhemorrhages, and they're generally not present in other conditions. What's the pathophysiology? We don't have time to go into great detail, but the initial pathophysiology is cerebral vasodilation, which causes stretching of nerve fibers along the vessels and pain. It's thought that it probably activates that trigeminal vascular system, although that's not entirely clear. If the cerebral vasodilation behaves as normal, you increase your ventilation, your oxygen saturation, your vasodilation subsides, and you feel fine after a few days. That's the process of acute acclimatization. However, this mild elevation in ICP, if from vasodilation. If it's sustained because you don't increase your ventilation appropriately, or you have sleep apnea, or you develop HAPE, then you can be tipped over into high altitude cerebral edema, in which case ionic starts with cytotoxic edema with cell swelling and no net change of fluid in the brain, since it just goes from the extracellular to the intracellular. But then we get actual transport of water across the blood-brain barrier, which is mostly mediated by aquaporin 4. If it continues and becomes more severe, we get more severe increase in ICP. We get more blood-brain barrier disruption, such that erythrocytes can transfer through the blood-brain barrier. And at some point, there might be complete breakdown of the blood-brain barrier, unlikely before death in these situations, more likely in ischemic stroke. What's the role of HAPE in high altitude cerebral edema? Well, if you have HAPE, you're going to suddenly be at a much higher altitude because your arterial PO2 is going to be even that much worse. And of course, that could also change intrathoracic pressure. The treatment of cerebral edema is oxygen and descent and dexamethasone, which is all you can do in the field. And you're hoping you're not going to suffer any long-term sequelae, like you may have noticed in me from my ascent on Everest. I have a hard time putting a talk together. No. Then there's high altitude pulmonary edema, first described in Colorado in the English literature or language by Charlie Houston in 1960 in the New England Journal of Medicine. You don't have to be at extreme altitude to have pulmonary edema. This kid came to my clinic in Telluride. He just happened to be wearing that t-shirt, and his oxygen saturation was about 58%, and sure enough, he had high altitude pulmonary edema. What's the pathophysiology? The sine qua non of high altitude pulmonary edema is excessive pulmonary hypertension due to excessive hypoxic pulmonary vasoconstriction. We've measured this with Swan-Ganz catheters on the side of mountains, and nowadays, of course, everybody uses echo techniques. You can see that the tricuspid regurgitation jet envelope is much greater on acute ascent to high altitude. And the current thinking is that although everybody gets pulmonary hypertension to some degree on ascent to altitude, it's those with uneven hypoxic pulmonary vasoconstriction that develop overperfusion of the areas that aren't protected. And indeed, clinical studies from the compounded Margarita in Europe have shown that at a capillary PO2 of about 28, calculated from measurements here, that the blood gas barrier starts to leak, and there's an extravasation of fluid into the interstitial space and into the alveoli. So the mechanism is uneven hypoxic pulmonary vasoconstriction in susceptible individuals. What's the treatment? Sorry about this slide. The treatment is oxygen and descent, which is all you can do in the field. In Telluride, we use bed rest and oxygen and keep them there. But in the field, you have to get down to lower altitude. Pulmonary vasodilators can be useful, although not nearly as useful as oxygen or descent. So somebody gets high altitude pulmonary edema in the death zone, they have to get oxygen or descent, or preferably both. They might benefit from dexamethasone. It's too late for calcium channel blockers or other pressure modulators. The mystery of acclimatization is where the future of this science lies. And here's my story to tell you how impressive this is. So I had reached the summit of Everest, which you see here, at 29,000 feet on low flow oxygen. I was extremely hypoxemic, but fairly well acclimatized. 2 weeks later, I was on a jet traveling from Kathmandu to Bangkok, and I was looking out the left side of the jet. And the pilot said, "Ladies and gentlemen, we are now traveling at 29,000 feet. I looked out there, I saw where I'd just been standing. And I realized that if that plane suddenly depressurized, I would be the only one that could survive. I would stay conscious. I could survive for hours, whereas everyone else would be unconscious within 1 to 2 minutes and dead within, nobody knows for sure, 5 minutes to 10 minutes. obviously not considering possible decompression sickness. But that's the power of the acclimatization process. And it's still a mystery. Yeah, we know that there's an increase in ventilation. We know there's an increase in oxygen carrying capacity. But oxygen carrying capacity doesn't tell us everything we need to know. There's changes going on in the mitochondria, in the cells, in metabolism that we really don't understand. So the future directions are going to deal with HIF molecular mechanisms. You can target on many levels. The holy grail is to find how to target specific HIF activations in downstream products instead of HIF overall, which can have a lot of negative effects, for example, like growth of tumors. You may have seen in this week's New England Journal that prolyl hydroxylase inhibitors, which augment HIF, are being used to treat anemias of chronic kidney disease, which is not brand new, but there's a couple of new studies that have come out. The altitude pill is what the military is looking for. They would love to give a pill to soldiers to help them acclimatize before they go to insert it into a high altitude without having to go to pre-acclimatize first. No one has ever taken an animal that's acclimatized to high altitude and just transfused their blood into an animal that isn't, see how they do. Of course, that could lead to a lifelong fishing expedition, but those kind of experiments would be very interesting. And I know the Altitude Research Center at the University of Colorado is interested in doing that. Modulators of aquaporin 4 and cerebral water metabolism could be very important. Diamox of cetazolmide has some effect on this, and there's other things. And then, of course, we want to simulate Tibetan gene expression, the special variations of EPAS1, for example, which is involved with the HIF pathway that actually causes it to downregulate so that they don't get too polycythemic. And then the story of pre-acclimatization. Well, going back to our initial case, Lincoln Hall and who all very nearly died, and Tom Hornbein, who amazingly escaped. We see that humans indeed can survive at very, very low levels of oxygen, or arterial PO2s in the mid-20s, that it may not be ideal, that eventually they're going to suffer consequences. But just think of the implications this has to your patients in the ICU with COVID or respiratory failure or other problems. What if you could somehow get them to acutely acclimatize so that their organs aren't damaged by either the very low oxygen levels or by having to give very high oxygen levels and inducing oxidative damage on that basis. So those are my thoughts for today. Look forward to discussion. Thanks very much.
Thanks, Dr. Hackett. That was fantastic. I appreciate you giving this talk. There's a ton of questions. There'll be more than we have time for. They sort of try to get them in categories if I can. The first is, it's a personal question. What did it feel like to be in the death zone? So, something we can't read about unless we ask you.
Yeah, good question. It's extremely uncomfortable. You have no appetite. It's to make water, you have to melt ice, which is very difficult to do. So you're always dehydrated and thirsty. It's extremely dry, extremely cold, hard to stay warm. Sleep is very fragmented and fitful. You do not want to get up in the middle of the night to take a leak when you have to put on a down suit, boots and crampons, or else you'll slip down the mountain and die. I mean, there's all sorts of variables. But the lack of oxygen mostly produces a rather profound apathy and lethargy and the sensation of cold. And using the oxygen is the only way for most of us. About 3 to 4% of climbers now go to Everest without oxygen, which is remarkable. But they also have a higher death rate. So it's not a good place to be. I don't highly recommend it.
Fair. A couple of questions about HAPE and HACE. Why is that response idiosyncratic? Why do some people travel to altitude multiple times before having a reaction and then can travel again without pathological effect?
To some extent, that's a misperception because most people who travel to altitude and get HAPE, for example, if they just go more slowly the next time, they won't get it. So I have a lot of patients that get HAPE on Kilimanjaro because they go to 19,000 feet in 6 days. But if they go to Everest Base Camp in 9 days, they're going to be fine. But it does happen sometimes. And some of that's just hard to explain. There may be intermittent infection. Any respiratory infection is going to increase the capacity for or a tendency towards lung leakage. That's been shown in multiple studies. And there may be obstructive sleep apnea that develops later in life, or other problems, decreased lung function with aging that make a difference from time to time. But usually it's rate of ascent and, of course, overexertion. Somebody overexerting at altitude is much more likely to get HAPE. There is a school of thought that anyone can get HAPE if they go high enough, fast enough. I don't know if that's entirely true. Certainly anyone could die if they go high enough, fast enough. And it might be more cerebral than pulmonary, but there are people that are particularly predisposed to high altitude pulmonary edema, have multiple episodes. They have lower nitric oxide production in the pulmonary circulation. They might have higher endothelin. They might have a little bit of pulmonary hypertension to start with, or just with exercise. I mean, you might have little diastolic dysfunction, which is exacerbated by going high altitude.
What do you think, or how do you explain, what's the causative factor for the uneven vasoconstriction that we see in HAPE and this non-homogeneous lung effect?
That's $1 million question. The thinking for a long time has been that it's due to residual muscularization of pulmonary arterioles from when we were in the uterus. That when we're born, we have highly muscularized pulmonary arteries because we don't want any blood flow to go to our lungs. It has no air. We want it all to go to the placenta. Once we take that first breath and the lungs inflate, that pulmonary muscularization resolves over years. And some of it resolves faster than others. And the thinking is that some it just doesn't resolve as much. That is one end of a bell-shaped curve. There's likely other explanations, but I don't know.
Yeah, I knew that was gonna be a tough one and a bit of a mystery. I apologize. We have a lot of questions from a lot of your friends here in Colorado. So Dr. Bull is curious if you can comment on the heart rate response to extreme altitude.
The heart rate response is interesting. It seems there's tachycardia at a set altitude that's thought to be both sympathetic stimulation as well as parasympathetic withdrawal. The heart rate response with exercise and even is very interesting. It seems to match cardiac output quite well. So if you give a beta blocker to drop heart rate at altitude, stroke volume increases, cardiac output stays the same. If you give atropine to increase heart rate, stroke volume drops, cardiac output stays the same. So it seems to be pretty well regulated to the cardiac output. But in general, people are going to be have a resting heart rate at least 10 or 15% higher than at sea level.
Thank you. Dr. Chan has a question for you. It's a question that says, if you took an unacclimatized person and you drop them to the top of Everest using some sort of a helicopter, admitting that that person would pretty quickly die, but they required no exertion to get up there, would they become tachypnic or dyspneic? And he asked this question in the sense of the question with the happy hypoxemic with COVID-19.
Very good question. How many of you would like to volunteer for that study? There are heavy lift helicopters that might be able to do it. I think that this whole happy hypoxemia thing has been equated to people at high altitude. You know, there was a flurry of activity about that. And my colleagues and I actually wrote a couple papers saying, look, this is not high altitude illness. And it's entirely different pathophysiology. But at rest, without exertion, even though you're breathing maybe 3 or 4 times more than at rest at sea level, you may not even notice it. So your tidal volume might go up from 500 to 700, your frequency from 12 to 14 or something. That may not even be very noticeable. And so you may not really feel short of breath until you get to a critical saturation. So when we do hypoxic ventilatory drive tests, we have people on rebreathers, the CO2 is scrubbed. We take them down. We see a huge increase in ventilation when they do get their saturations down in the 70s, but not in the 80s and 90s. So on the summit of Everest, if you didn't have supplemental oxygen, you would actually get in the 60s pretty quickly. So I think after a time, you would start to feel shorter breath. And these patients with COVID, I don't know if they're partially acclimatized because it's developed over days instead of hours. That can make a big difference. Or if there's some evidence or thinking that the virus itself might attack the carotid body and interfere with carotid body function, or maybe others, well, that would be the main thing. So it's not clear, but this happy hypoxemia thing isn't all that surprising, but may have to do with acclimatization or may have to do with damage to the carotid body. I don't know. And you take normal healthy people, there's a bell-shaped curve. You make them extremely hypoxic. Some are going to breathe like stink, and some are just going to turn blue and be comfortable.
Yeah, I remember as a fellow reading that research from yourself and Dr. Weil and Dr. Zwillik, but there was a question about that. Can you explain a little bit about the genetic effects of hypoxemia and how people respond differently to that?
Well, with HIF modulating 4,000 or 5,000 different genes, and every one of those genes having a different polymorphism, multiple polymorphisms, you can understand the genetic variations are remarkable. So some, like some with Chuvach polycythemia have a defect, have a polymorphism in their HIF sensing pathway. So they sense hypoxia when it isn't there, and they get extremely polycythemic. And others are on the opposite end of the spectrum. So their HIF might be very suppressed. So HIF biology could explain a lot of that. But then there's polymorphisms in aquaporin 4, aldosterone sensors, kidney function. I mean, there's so many. So it's not surprising there's a lot of genetic variation. I focus on ventilatory drive and water balance in the brain, but there's genetic polymorphisms to explain many things.
Mm-hmm. And speaking of some of these genetic variations, Dr. Schwartz has a question for you, which is, how have Sherpas adapted to physical exertion at high altitude? And what are the long-term beneficial and detrimental health implications of that chronic adaptation?
Yeah, good question. So Sherpas have adapted. Sherpas are fascinating. I don't have time to go into it, but they have an EPAS gene. They're part of the Tibetan lineage, like my yak do out in the yard, and a polymorphism that modulates the HIF pathway. And they have many other adaptations. But interestingly, that polymorphism on the HIF pathway was introduced by a Denisovan population, which was an archaic hominid that introduced the gene into Tibetans about 50,000 years ago. It was not natural selection. Very interesting story. Anyhow, they do extremely well at high altitude. They don't feel like they have any limitation. If you put them down here at sea level, they can do about the same as us. But you take them back up to altitude, they have no decrement. So they can do almost sea level performance at higher altitudes. And there's been a lot of studies on Sherpas and their different metabolism, their myocardial cell structure and metabolism. Obviously, you don't have time to get into all that. And they have normal birth weight babies. They don't have pulmonary hypertension. They have all sorts of adaptations that have evolved or been introduced over thousands and thousands of years. The benefits of that are that they can perform extremely well and that they can have healthy babies and reproduce and continue to live at 12 to 14,000 feet. The downside is that it's not that much in Sherpas. I mean, they don't get chronic mountain sickness like the South American Indians do, because they don't get so polycythemic. They don't get the pulmonary hypertension and right heart failure like people in Leadville or people in Morococha, Peru do. They seem to be protected from all that. They probably do have an increased incidence of stroke and high blood pressure. It's thought to be related to a lot of their diet is so salty, but So Dr. Schwartz, I think the thing to do is before you do your trip to Everest Base Camp or Kilimanjaro, we do a transfer of Sherpa genes into you, and you'll do just fine.
We'll take care of that locally for him. Dr. Hackett, what about, we have a lot of patients obviously that live up in much higher altitudes and then including Leadville. What degree of this adaptation do we see in those populations?
Good question. I didn't have time to go into how this all applies to people in Leadville, but the people in Leadville do get a polycythemic response, which can be beneficial or harmful. They do have, in fact, interrupted sleep. They do have higher incidence of chronic headaches and obstructive central sleep apnea. They do have reduced birth weight babies, but they're small for gestational age. They're not premature. And so they do have health problems related to that. I think if we can find the key to acclimatization without using supplemental oxygen, I mean, to protect these people, we may be able to help them in the future live and perform better at high altitude. In my practice, which is limited to high altitude medicine, I get people from all over the state. One of the most common questions is, I'm not doing so well at high altitude. I'm thinking of moving down to Denver, or even moving lower. If we had something to offer those people besides oxygenating their home or keeping them on supplemental oxygen, it could be a big boon.
Mm-hmm. I hope we have time for two last questions because there's sort of two big buckets we haven't covered yet. I don't know if this was Dr. Cornwell's question or not, but I know he's on. What's the time frame that's required for athletes training at altitude to derive a benefit and an increased performance?
To derive the benefit of altitude training, I mean, that's rather controversial because there's, the question is whether it really works at all. And obviously there's some responders and non-responders. That seems to be the problem. For those that respond, most of the studies show 2 to 4 weeks. Or even Ben Levine's studies were 4 to 6 weeks, I believe. And for those athletes going to perform at altitude from sea level, they need 10 to 14 days to get to a decent athletic ability to recover, which of course nobody has time for.
Right, of course. And we have a question, I believe came from some of our primary care audience, which is there a risk calculator for folks leaving sea level or lower non-sea level altitudes to go to higher altitudes? Or do you have to directly test them to know what the effect is going to be?
Well, that's a really good question. Yeah. There's nothing you can do easily. So I recommend to my patients that if they have concerns, that they just stage their ascent. They go to Denver, see how they are there. Then they move up to Boulder or a little bit higher before they take the jump to Summit County and see how they do. There are studies using hypoxic gas mixtures in order to try to predict who's going to get sick at high altitude. There's some success with that. They do it a fair amount in Europe, but it requires a specialized laboratory, and it only helps predict those that are likely to do really poorly. So the bottom line is, it's not worth getting pulmonary function tests or echoes or exercise tests on your patients that want to go to high altitude in terms of understanding how they're going to perform. They have to get out there and see how they do. And in general, given the same rate of ascent, they'll do about the same each time.
That's great. Thank you. Well, it is exactly 1 o'clock. There are unanswered questions, but that's life. But Dr. Hackett, I really do appreciate you being here. It was fantastic talk, a brilliant life that you've lived, and thanks for sharing all that with us.
Great. It was great to be with you all, even virtually. Happy holidays, Happy New Year, Merry Christmas, etc.
Happy holidays, everybody. Thanks.
Bye.